Hello, good evening, everyone. Yeah, please just comment about the voice. Is the voice is good or not? Is it clear? Good evening, Dr. Sparna. Yes. Okay, perfect. Perfect.
Hello, good evening. Yeah, perfect. Yeah.
Okay, thank you. Okay. So, I'm Dr. Mohammed Hasan, and I will be today with all of you in our free session about selective topic discussion in relation to Part 2 curriculum. Today, I will be very happy to discuss a laparoscopy and hysteroscopy guidelines, a green top guidelines, so that we can give a good idea about how can we conduct our course about Part 2 and to prepare for this exam. Part 2 examination, as we said before, is one of difficult, tough exams you will ever meet in your life. And in comparison to last patch of the exam, the last one was somehow very tough in EMQs. So we will try in this patch of our course to give more interest and concentration on EMQs question. How can we think about, how can we deal about? But today, actually, we have to understand the important point in green top guidelines. How can we read the guideline and how can we summarize it? It's a very important advice to all of you, my dear friends, to when you are start reading green top guidelines, you should do your own notes or your own summaries, a handwriting summaries, and by your own words, so that when you are very near for the date of the exam, you can revise it easily. One source, summarized information, will be very helpful the last week before the date of the exam. Okay, laparoscopy, you should cover the laparoscopy as a part of surgical skills domain, and sometimes the post-operative complication questions in Part 2 exam, as well as in Part 3 exam as well. So the green top guideline is the main source, and it's advisable that you should read a consent advice guideline or clinical governance guidelines related to the laparoscopy. Okay, so let's start our session. Okay, this is a gynecological laparoscopy. This is another one. Okay. The main aim of this guideline actually is to be safe during your procedure, and the patient safety is the most important domain in each examinations in UK, particularly Part 3 and obviously in Part 2 questions. So the patient safety is very important, not only in laparoscopy, in hysteroscopy as well, in open surgeries, in placenta previa management, in blah, 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 whatever. So this guideline, starting with the purpose and scope, complications, and you should cover these complications, as we will discuss later, from the consent advice guidelines, and possible laparoscopic injuries that may be associated with insertion of needles or trocars, or during manipulation of different surgical procedures by the laparoscopy. Okay. The incidence of complications, all of these numbers are very important in single best answer questions. So it accounts about 2 in 1,000 typically in questions the major complications will be around 1 in 500. 1 in 500. Including the most common injury is intestinal injuries or bowel injuries during insertion of trocars. Urological injuries, either ureteric or bladder injury, count about 0.3 out of 1,000, and vascular injuries is 0.1 in 1,000. This is according to Clinical Governors Consent Advice Guideline. And the most important thing actually is you should remember these complications, because when you are taking a consent from a patient before going to theater, or when you are discussing the procedure with the patient, you should fulfill all possible complications during the fulfillment, and you should discuss these complications with the patient. This act actually, through the medico-legal aspect, is explained by a Montgomery Act. A Montgomery Act means you should tell the patient every possible complication associated with this procedure, varying between a common complication up to very rare complications, so that the patient should be aware about all possibilities and she should accept all possibilities. This is called a Montgomery Act. Okay. This guideline, the Consent Advice Guideline, classifying the complications into frequent risks or common, which are wound bruising, wound gapping, or wound infection, and shoulder tip pain. The same guideline classifying other complications in a serious or uncommon complication, like bladder injury, bowel injury, vascular injury, failure to gain enter to the intraperitoneal space, okay, and other complications related to anesthesia and overdistension of the peritoneal cavity associated with cardiopulmonary compression. Okay. For that sake, as all of us are interested in safety of this patient, so the Green Top Guideline advise for many steps that you should take care about, so that you will decrease the associated possible risks with laparoscopic entry and surgical procedure. All of us, you should remember that surgeons should have appropriate training and supervision with experience, familiar with equipment, instrumentation, and ensure that the instruments all are working well prior to start the procedure. For example, you should make a test for a light source for the pain to check the varus needle, for example, prior to insert it, the insufflator machine. You should ensure that all equipment are working in a good way prior to start, okay? And assistants should be on high level of training, and the nursing staff as well should be well trained. This is the general information. And now about the laparoscopic entry techniques. The Royal College recommends, as almost all of us in daily practice working like this, the closed technique of entry. This is our best way to get inside the peritoneal cavity using the varus needle entry technique insertion. The varus needle entry technique insertion, it depends on subumbilical insertion at the base of the, not at the base of umbilicus, insertion of the vertebral, and insufflation should be started by the rate up to 20 to 25 millimeter mercury. This is the recommended intraperitoneal pressure before entry of main trocar and the two or one accessory trocars or secondary ports. So any insertion of the port, either primary or main trocar or secondary port, should be under pressure of intra-abdominal space 20 to 25 millimeter mercury, not less than this, to avoid possible injuries. Yes. After insertion of your port, primary port, which is the camera actually, you will start your procedure, either a diagnostic laparoscopy or even a surgical procedure. The pressure will be decreased to 15 millimeter mercury, 12 to 15 millimeter mercury, so that you can start in a less pressure, intra-abdominal pressure, aiming for decrease the possible cardiopulmonary compression and decrease the possible complications with high pressure, I mean. Okay. This is about the recommendations of entry. The entry of any port should be by the right angle on the skin. So 90-degree insertion of the port, either primary or secondary as well, is the recommended angle of insertion. If you would like to insert a secondary port, it should be under vision. Primary port, which carrying the camera, taking a look inside, then prior to insert the secondary port, it should be visualized using this camera. The entry as well as the exit of the port should be under complete vision by your primary port camera to avoid a major complication and very common complication, AS, inferior epigastric artery. Inferior epigastric is running in this point actually, and it's a branch of external iliac artery. I mean, the bleeding will be horrible, okay? A severe bleeding. And sometimes it requires turning patient to a laparotomy. So, under vision, either insertion of the port or extraction of the port after finishing your procedure. Sometimes patients in a high risk group to avoid inferior epigastric and extreme, yes, can get injured single piston. Very common. Yes, it's very common. And sometimes when the inferior epigastric artery being injured, the injury sometimes is invisible. So the peritoneum covering the course of the inferior epigastric will be still intact, and the blood vessel will be injured and retracted. So post-operative follow-up of this patient sometimes suffering from a hypovolemic shock with free intraperitoneal cavity and only subrectus hematoma will be your landmark for inferior epigastric injury. So inferior epigastric is a very tricky artery. You should take care of it, actually. Okay. There is a high risk group of patients that the college not recommend varus needle entry technique or closed entry technique with them because they are more liable for complications. This group includes extreme body mass index. Extreme body mass index, either very low or obese woman. Okay, obesity will sometimes be difficult to introduce properly in a normal pathway and to get inside the intraperitoneal cavity. And with thin patients, liability for vascular injury to a major blood vessel like abdominal aorta or common iliac artery with very thin patients is very common. So, okay, so don't take out the scoop, but see from the second report. Sorry, didn't patient aorta? Yes, abdominal injury aorta or even a common iliac. Okay, other patients include also included in this group those who had a previous intraperitoneal surgeries. Specifically, patients with a previous midline laparotomy. Midline laparotomy is associated with 50% risk for intraperitoneal adhesion, as well as a 23% risk of intraperitoneal adhesions with transverse abdominal incision. So previous intraperitoneal surgeries, sometimes patients with expected intraperitoneal adhesions like those who had previous attacks of PID, chlamydial PID infection, or patients suffering from endometriosis. Okay, so all of these patients should be treated in a specific way. Even if you would like to connect some informations together from different points in the curriculum, for example, in infertility, the same high-risk group of intraperitoneal adhesions we are talking about right now, if the woman came to fertility clinic with subfertility issues and you would like to check her tubes, for example, you cannot offer her a simple investigation for a tubal assessment, patency assessment, like hysterosalpingography. Okay, you should offer them diagnostic laparoscopy or laparoscopy and dye test. Why? Because they are at more risk for intraperitoneal adhesions, so you should offer them a definitive investigation. This is just to remember that a high-risk people, the college see high-risk people from another point of view. So you should take care when you are answering these questions, okay? So why no slide coming for me? I think the slideshow is visible to most of candidates, am I right? Yes, okay. So, doctor, please, you can relog again. So maybe the screen will be apparent after that. Okay. Yeah, relog again, please. So, okay. How can we manage those high-risk patients? We have two possibilities. The Royal College of Surgeons in England or UK recommends open Hasan technique or approach. It's a mini laparotomy incision in the same site of varus needle closed technique port insertion, sub-umbilical at the base of the umbilicus, will be done, and then you will get inside the intraperitoneal cavity by a mini laparotomy surgical steps. You will open the subcutaneous fat, sheath, muscle, and then get inside. Okay. Okay, I'm just changing now the get back again to the previous slide. Please show previous slide when you finish. Okay. Nothing new. I will start again from this point, and as well as I will keep talking in the same point. So this is a Hasan technique. Hasan technique is associated with decreased risk of injuries, but statistically, the main injury which had been markedly decreased with Hasan technique in comparison to closed technique with high-risk patients is vascular injury. Vascular injury. This is a very important point in different questions. Okay, very important point. Another way how you can manage a high-risk patient rather than open technique, sometimes you may enter the peritoneal cavity from another point, like a Palmer's point entry, which is located 3 centimeters below the left costal margin in the mid-clavicular line. 3 centimeters below the left costal margin and the mid-clavicular line, away from the possible adhesions inside the pelvis or around or whatever. It will be ideal. Hello. Okay. So she or he closed the mic. Okay. Okay. Then the Palmer's point will be ideal in some conditions with expected extensive pelvic adhesions. Unfortunately, it's not regularly used in our practice, and sometimes most of our consultants are not experienced enough in using Palmer points, although it's recommended by the guideline. The contraindications, by the way, for a Palmer's point entry, for those patients who had a history of left hypochondrial area previous surgeries, like splenectomy, or a previous splenic hematoma evacuation because of expected possible adhesions at the same point. Okay. Okay, this is about the possibilities of how can you enter the peritoneal complications as you can to avoid injuries. This slide shows the intra-abdominal pressure during entry of the port, and the pressure should be reduced to 12 or 15 as we said before. Okay. Okay, Hasan technique, alternative techniques. Perfect. Let's go. Second report. The woman who is obese, Hasan technique or entry Palmer's points are recommended. A varus needle is used. Care must be taken to ensure that the incision is made at the base of the umbilicus. Okay. As well as those women which are very thin. The guideline said the aorta may lie less than 2.5 centimeters below the skin in those women. Okay, I can't ever believe that 2.5 centimeters below is a possible distance between the skin and aorta, but the guideline says this number actually. So you should remember this number as well, although it's unbelievable number. Okay. When you are talking about the consent, okay, you should put some important scheme in your mind during taking the consent and some important rules as well. So from my point of view and from my own notes, I can remember that consent should be number 1. straightforward, clear data. Number 2, no abbreviations during taking or fulfilling the consent form. Number 3, the name of procedure should be written in a lay language. I mean, for example, laparoscopy for ovarian cystectomy, removal of cysts in the ovary using keyhole surgery. You should write in the consent form like this, in the lay language. So removing cyst from the ovary through a keyhole surgery. Keyhole surgery resembles laparoscopy, but in lay language. Number 4, explain the steps of procedure to the patient. Number 5, explain possible complications as we discussed before. Number 6, in the consent form, a very important item, you have to discuss possible additional procedures. In laparoscopy consent form, for example, you should discuss with the patient possibilities for laparotomy. If the patient is refusing laparotomy, you cannot proceed with laparoscopy. Okay? This is called additional procedure. For example, if you are taking a consent for instrumental delivery, you should add in the consent form possibility for emergency cesarean section. Okay, this is an additional procedure. Number 7, you should fulfill the item of anesthetic review. Anesthetic review. Number 8, you should check yourself. A very important 2 items related to patient safety. First, allergies to different medications. Allergies. Second, blood transfusion acceptance. Many scenarios playing on these 2 important safety points. Allergy and blood transfusion. Okay. Finally, the consent form should be signed out by yourself or a doctor and the patient as well. Okay. This is the point always inside my mind when I'm thinking about the consent. Okay. About the consent. Perfect. There is serious complications. We said 1, blah, blah, blah. Okay. Frequent risks. Sometimes we are repeating these points and we discussed these points before. Okay. In exam, as we said, laparoscopy questions will come in a single best answer tool. Direct question about the pressure, intraperitoneal pressure, or the angle of entry, or the type of technique of entry, which technique is better. But in EMQ's question, the laparoscopy guideline will come like an EMQ of post-operative complication or intraoperative accidental injury. So let me give you a very small points about how can you manage generally. How can you manage accidental injury during laparoscopy? Number 1, inform the whole team in theater about your suspected injury. Inform the anesthesiologist. We have a problem. We may extend the planned time for this surgery for a while. So take your responsibility about this problem. The nurse helping you, your colleague, and then according to the injury, you should inform your consultant. And if it's a vascular injury with bleeding, you should think about, for example, this is a particular point. If the lesion is vascular, I will think about cross-matched blood. But if, for example, the bladder is injured or bowel injury, I will think rapidly for anybody can answer this. Anybody can answer this. If you have a bowel injury or a bladder injury, you will think rapidly about no. Dr. Rana, laparotomy, if there is no experienced surgeon can deal with a problem laparoscopically, or the patient is vitally unstable. Otherwise, you will manage through a laparoscopy. Okay, I will tell you the answer is very easy. I will answer it like antibiotics. Okay, antibiotics. Remember, no prophylactic antibiotics prior to laparoscopic procedures. Okay, please, everyone check your mics are closed because of the echo of the voice. Please. Dr. Ritika, please close your mic if possible. Thank you. Exactly. No antibiotic. Antibiotics using in UK is very limited to certain conditions. It's, for example, related to a laparotomies, just prior to a laparotomy surgery, I mean. But prior to hysteroscopy, prior to laparoscopy, prior to insertion of IUD or DNC, if the woman is already swabbed and she is negative for infections, no need for prophylactic antibiotics. So, with bowel injury and bladder injury specifically, urine and feces may lead to a chemical reactionary peritonitis. So you should give the patient rapidly prophylactic antibiotics. As well as you may take a decision within 15 minutes to turn the laparoscopy into a laparotomy. So you already give the patient antibiotics. No, you will give them antibiotics until repair of the problem or until the support of your consultant or your surgeon or whoever consultant being inside the theater according to the problem, being with you and helping you to correct this problem. Okay? So you need to think all of the time about what is, okay, for example, if the inferior gastric artery is injured, don't say to me that the first step is prophylactic antibiotics. It's unlogic. The most logic thing, you expect horrible bleeding or excess bleeding, so you will ask for cross-matched blood. This is more reasonable. Okay? The next step is you should only ensure hemostasis, otherwise stop procedure. Don't go through the procedure anymore or furthermore until the help is being with you, because you may extend the lesion. In that sake, don't play with the instruments inside. I mean, sometimes reflexly, when I trying to get inside the intraperitoneal cavity and during insertion of the trocar, I am making a major injury to the bowel. by reflex, I will withdraw the trocar outside. Am I right? Anybody before? I hope no one went through this experience before, but I'm just asking because it's very a reflex natural movement that when you think that you have an injury with insertion of the trocar, you will withdraw the trocar outside. Okay, this is a major mistake. You should leave the trocar in situ. Don't move, because this action, the withdrawal action, may extend the primary injury as well as it may lead to another injury. Okay? Only thing you can do, you may, being inside or insert a secondary port, and then you can take a look, put the camera from the second port to take a look for the primary port. I mean vice versa. It's now the opposite way. Not the primary one who is looking for the secondary one. I mean the secondary one, you can see the primary port through the secondary one. Okay? It's very important. Yes. According to your problem, you will ask for a help. You will ask for a help. Okay? And normal sequence. Okay. Okay. The normal sequence of the patient is management inside the theater room, and then put a plan for the post-operative follow-up, which will be discussed right now after finishing this one. Anesthesia is not your problem. Okay. The very famous TOG article is talking about urological injuries associated with laparoscopy. Let me explain a few points, very important few points. Due to rising of medico-legal aspects inside the UK and the huge claims coming from the gynecology procedure or practice, you will find some numbers or incidences are very high than expected. For example, the laparoscopy may miss bladder injury by 50% of cases. Wow. It means that I may have a bladder injury during a laparoscopic procedure, and the surgeon may miss this injury up to 50%. Okay. 15% of bowel injuries will be also missed during the primary surgery. I mean, now we are in theater, getting inside for a patient of endometriosis, too much adhesions, you try to do adhesolysis, bowel is injured, you will miss diagnosing this injury, 15% of cases will be missed. So the point is, laparoscopy Okay. Is the voice coming back? Okay, perfect. So this is just a drop in the network. Okay. Yeah. So it's very important to follow up the patient post-operatively very carefully. as well as exactly those patients of laparotomy. Most of us thinking about laparotomy as a critical procedure with more complications. But definitely, laparoscopy is associated with hidden problems that may be represented later. And then the problem will be more difficult to be managed. Urinary bladder is at risk of injury during laparoscopic procedure. Bladder is the most common viscous to be injured during total laparoscopic hysterectomy, particularly. Okay, particularly total laparoscopic hysterectomy during dissection of bladder from the anterior, lower corporeal and cervical portion. And the 50% of bladder injuries will be missed. Okay. Bladder injury management is definitely very easy surgically, but it depends on post-operative specific care. Yes, specific care. During the dissection of uterovesical area, mostly the bladder may be injured, either a superficial injury or a complete full thickness injury. The injury rates range between very, very, very low risk up to 8%. 8%. Okay? Okay. Okay. How can you manage a patient with a bladder injury during the procedure? I need suggestions. Okay. Let me talk about the primary management. All of you knows that 2 layers of non-absorbable sutures, 2-0 vicryl, non-water tension sutures should be taken, and then a test should be done to confirm non-leakage suture line. Okay, non-leakage suture line. Now, this information all of you knows about, but Royal College wants another thing. Royal College at this point wants what are the points of patient safety you have to know and remember and do for a patient with bladder injury, starting from intraoperative time up to post-operative follow-up. Any suggestions? If you have a patient with a bladder injury inside theater, any suggestions? I told you about antibiotics, for example, prophylactic antibiotics. Am I right? Okay. I need interaction. What do you think? All of you. Anybody wants to talk to me, he can open the mic, or even to write. Yes, documentation, incident report. Perfect. Debriefing. Excellent. But all of these things is most post-operative. If you would like to remember something intraoperative, I will be very happy. What do you do inside your real action, your real life action? Catheter, instead of fully catheter, for 7 to 10 days. Yes. Methylene test. Okay.
We do.
Perfect. We all do this with antibiotics and catheter. Okay. All of you are thinking very well. Let me put something inside of all your minds. Don't ever forget in complications to leave intraperitoneal drain, either with bowel injury, extensive vascular injury, bladder or ureteric injuries. Intraperitoneal drain. very critical. One of our seniors, a long time ago, he said, vital signs for pre-graduate doctors include blood pressure, pulse, temperature, and respiratory rate. But for postgraduate doctors, there are 7 items, not 4. You should add conscious level, urine output, and drain amount of fluids to the vital signs of the patient. You can imagine the importance of the drains, ideally or particularly in complicated surgical procedures. After that, prophylactic antibiotics should be given intraoperative and postoperative because the presence of prolonged time Foley's catheter or silicone catheter to reduce the tension. Documentation includes operative details and debriefing for the patient and her family, incident report, and plan of follow-up visits. Sometimes you may need to involve one of other specialties consultants, and of course, root cause analysis and risk assessments should be done as well. Okay. Please, when you are thinking about post-operative care, always think about medications. And the critical medication in patient safety post-operatively is thromboprophylaxis. Always remember thromboprophylaxis. Thromboprophylaxis is a very beloved issue for the college. And actually, they are obsessed by low molecular weight heparin treatment. They are very obsessed about this. So I always say something like this. When you feel there is no suitable answer for the question, just choose low molecular weight heparin. It will be right because they like it. So, okay, this about the risk factors that may lead to urinary tract injury due to distorted pelvic anatomy by the guideline. Okay, endometriosis, cancer, obesity. Okay, no problems. Okay. The other organ that may be injured from the urinary tract during laparoscopic procedure is the ureter. And for all of us, like a gynecologist, ureter is our monster during procedures. Actually, that's right, because maybe 50% or more of gynecologists worldwide never seeing ureter before. They all of the time heard about the ureter. Don't put the clamp like this during hysterectomy. You will make an injury to the ureter. Don't take a very deep stitch. The ureter will be involved. So please, where is the ureter? Okay? Please, let me feel it. Let me see it. And that's the most important 2 things to identify ureter intraoperatively. The most common sites for ureteric injury is a very common question in single pass answers. Yeah, there are many types. The most common is a transection. Transection is the most common. But very common question as well also is a sites of common injury. The most common one is near to the cervix, 1 centimeter lateral to the cervix during total abdominal hysterectomy and removing the cervix by dissection of cardinal ligaments bilaterally. The other side, ureter during ligation of infundibulopelvic ligament. during oophorectomy, because the ureter is running just down below the ovarian artery, making a cross within an ovarian artery. So it's very common site to be injured as well. Okay? Okay. The ureter is best evaluate before procedure. Sometimes, and in different scenarios related to the exam, you should explore the ureteric pathway before going through the surgery. For example, a patient is now planned for total abdominal hysterectomy because of large fibroid uterus. Large fibroid uterus. You should explore ureteric pathway and the ureteric anatomy, because distorted anatomy is very common with a fibroid large uterus, as well as with cancer patients, as well as with severe endometriosis. So it's very ideal to examine the ureters prior to go through this surgery. How can I see the ureter? Either by imaging modality or another way of investigations. What do you think? What is the ideal way to evaluate ureters? Ureters will never be seen through, yes, now technique ureter stent. Okay. Okay. Stent. Excellent. All of you are right. All of you are right. Double J stenting of the ureters preoperative is the perfect or ideal way to evaluate the ureters. But if the question is asking for imaging modality, let me explain the investigations rapidly of the urinary tract from upside down. Intravenous urography or intravenous pylography, IVU or IVP, the main organ you would like to examine is kidneys. Kidneys. Okay. You will inject a dye. The dye will start as early as possible by filtration inside the kidney. So the first organ will the image catch is the kidneys. After that, the dye will be going downwards through the ureters and bladder, but ideally, I need using IVP for kidneys. So, this is not our aim in gynecology. So, IVP or IVU are never a good choice in exam. You should think about another options. So what are the other options? Let's start from down below upwards. What about, what about retrograde cystourethropy? Cystourethropy is by injecting a dye through the urethra and bladder and then taking a photo or an image. This is a cystourethropy for bladder evaluation. And this investigation is ideal after bladder injury evaluation or detection of fistulas. Fistulas. Okay? If you inject more dye, the investigation will be changed from cystourethropy to cystourethropy. Then the ureters will be involved through the dye injection. And this is the best way to evaluate the ureters. cysturetrography. Thank you, Dr. Suparna, for writing, actually. Exactly, uretrography. The other name of cysturetrography is even, no, we are talking a pre-operative. Intraoperative, the only option is cystoscopy and cysturetroscopy. Okay, if the surgeon is inconfident or cannot explore the ureters from the operative field, he will ask for a cysturetrography. No place for taking image during intraoperative complication. Okay. Del, please close the mic. Please. Del. Hello.
Yeah.
Please close the mic. Too much noise.
In the majority of cases,
Hello. Del, please close the mic. Hello. Okay, thank you. Okay. Perfect. Now I can now I can continue. Okay. So what I said the last thing. Yes. Cysturetrography. If the image is taken by X-ray, a plain X-ray, it will be a retrograde cysturetrography. Ideally, CT imaging with contrast is ideal. So CT cysturetrography is CT urogram. And this is the best option to visualize the ureters. Okay. We will change the slide. The slide now is talking about the suturing of a bladder injury, which have been already discussed before Dr. Rana. Okay. CT urogram pre-operative, Dr. Suparna. No place to use imaging intraoperative. Intraoperative, ideally, to visualize it by a surgeon himself. If the surgeon is incompetent or less experienced to visualize or expose, yes, okay, perfect. So the stenting by cysturetroscope is ideal. What about illegal ISN? No, not recommended. Not recommended. The dye is not recommended by the guideline itself. Okay. How can you repair a ureteric injury? Very easy. It depends on the level of injury. Where is the injury? Exactly. If the injury is in the lower 1/3 of the uretary course, reimplantation of the ureter inside the bladder after excision of damaged area is ideal. And now questions appeared. Let's see. What is the value of preoperative? Just to detect the ureters? Yes. Sometimes, Dr. Rana, the ureters have been markedly displaced far away from their course or normal course due to large fibroids, due to severe distorted adhesions of the pelvis with endometriosis or cancer patients, actually. So it's very important to clarify the pathway of the ureters prior to get inside the abdomen and doing your procedure, aiming to minimize the risk of ureteric injury. So this is ideal. Okay. So with the lower 1/3 of the, thank you, with lower 1/3 of the ureters, it's very easy to making reimplantation again. Okay. Even post-operative cysto-ureterogram, yes, the best imaging modality, cysto-ureterogram, which resembles also, if you are using a CT, it's a CT urogram, the same technique. Okay, thank you. If the injury is in the upper 2/3, resection anastomosis will be ideal to manage the ureteric injury. If the injury is very high near the kidneys, which is extremely uncommon with our gynecology procedures, the ureterostomy may be an option. Please remember, with ureteric resection anastomosis, ideally stent should be placed inside to prevent extensive fibrosis during healing time, which may lead to ureteric stricture later on. Okay? This is about bladder catheter ureteric injury. These are the types of ureteric injury. As we said, transection is the most common by this TOG article. We have already a summary for the TOG article in 2 papers only. It will be very helpful to all of you to collect the ideas, and it will be sent to all of you as soon as possible. Okay, that's it. Please, in single best answer questions, sometimes they are asking questions related to a basic science. Anatomy is the major basic science you should cover for this exam, for part 2 exam. And definitely the anatomy questions are: number 1, blood vessels. What are the blood supplies, or what is the most common vessel to be injured? And what is the origin of certain blood vessels? Number 2, nerve injuries. Number 3, ureter anatomy. So the ureteric anatomy is extremely important. Okay. The ureteric anatomy, by the way, intraoperative questions. Wait, just to read. Excuse me. So intraoperative we can find by cystoscopy plus stent. Excellent. Yes, cysto-ureteroscopy, cystoscopy and ureteroscopy. Intraoperative using double J stent. Ideal. Okay. There was one scenario. Patient underwent laparoscopic removal of deep endometrial near pouch of Douglas. What artery is damaged? Okay. Endometriosis near pouch of Douglas. What artery is damaged? Okay, it's completely, there is no a certain artery running in this area, but you maybe the answer is a descending branch of uterine artery. If you went somehow deep in the Douglas pouch, in the posterior surface of the cervix, or maybe a branches of rectal arteries. Okay. But this is I don't know. I can imagine what is running in the Douglas pouch. This is one of the silent areas. Yes, it's difficult to be uterine itself. It may be a branch of the uterine, either a descending branch of the uterine artery, because you have to remember something. Uterine artery is coming from lateral pelvic wall, lateral and backwards. So the pathway is almost deep in the pelvis. But branches may be more superficial, okay? Branches will be more superficial. Okay, this is about the management of the, okay, take a minute. Maybe any vessel at the base of the bladder. Bladder is anterior. Bladder is anterior. Douglas pouch is the recto-vaginal pouch. It's posterior. So I think it's far away, Dr. Bushra, somehow. Far away. Don't talk to me about the bladder blood vessels. Don't talk to me because today just I finished abdominal sacrocolpopexy. Okay, abdominal sacrocolpopexy to a patient who had underwent hysterectomy 4 years ago, and she suffers from a vault prolapse. Okay, you cannot imagine how much the bladder is adherent to the vault. So to dissect bladder from the vault, it was like I can remember myself like a butcher. Too much blood, too much blood in a very narrow area and very critical area. So that I just remembered. Yeah, so that I just remembered when you are talking about bladder-based vessels. This area is horrible, by the way. So don't remember me about this. Okay, this is a surgical principles. All of you can see surgical principles of ureteric repair, anatomy of the ureter, technique of the ureteric insertion or surgical technique is not involved in our curriculum. Yes, maybe one of the rectal arteries. That's what I expect as well. Either a branch of a descending branch of ureterine artery or one of the rectal branches, according to the options. Okay, perfect. Let's go through another platform here is a guideline, a simple guideline, also related to in hysteroscopy. Your question, doctor? Scenario patient with, sorry, I need to. Patient with laparoscopic removal of bilateral hydrosalping with abdominal distension and fluid shift. Okay, abdominal distension and fluid shift. Intraperitoneal hemorrhage. Intraperitoneal hemorrhage. If the patient is showing a vital sign showing a hypovolemic shock, this is an intraperitoneal. Okay. I know what is inside your mind. I know. With a fluid shift, so maybe the bladder is injured and the urine inside. I know very well what is inside your mind. No way. No way bladder injury. Why? You should expect injury according to the site of surgery. You should yes. No. You should expect injury related to the site of injury. For example, I cannot say when I will, okay, for example, I would like to remember any good example for this. Your action on tubes is definitely far away from bladder. Very far away from bladder. You will never even touch the bladder during your procedure. So how come bladder injury leading to something like this? But the other option, if the creatinine level is given inside the scenario and it's high in the fluid inside the abdomen, this is a ureteric injury. This is a ureteric injury, not a bladder injury. Be smart. I said ureter is very close to the infundibulopelvic. Okay, and this is the site of injury of ureteric pelvic course. So it's very common to be injured. Thermal injury maybe, yes. Transection maybe. Thermal injury for tubal disconnection, or sorry, salpingectomy, yes. Thermal injury is the main cause for bladder injury, ureteric injury mainly. So it now it's accepted. But don't say that bladder injury is very far away from the site of primary surgery. It's completely far away. Okay, let's go through rapidly through a hysteroscopy guideline. It's very easy guideline and very common question, repeated questions actually. So look, the answer, if creatinine is lowered, it's ureteric injury. Exactly. If not, this is, or if the patient from the scenario is a hypovolemic shock, tachycardia, low blood pressure, this is an intraperitoneal hemorrhage. Okay, this guideline, as I said, the questions are repeatable. All what you need to know is a few informations about the important points here. The hysteroscopy indications, it may be diagnostic hysteroscopy as well as an operative indication, transcervical resection of myomas, polyps, taking biopsy with endometrial hyperplasia, unexplained bleeding, postmenopausal bleeding, Asherman syndrome treatment with adhesolysis. Sometimes hysteroscopy is used as a sterilizing or contraceptive method to insert a sure block of bilateral tubes origin or ostia block. So it may be used as contraceptive way. Of course, removal of foreign bodies, mainly IUD, if embedded inside the myometrial muscle. Okay, that's it. So the same problem here, you should fulfill the consent. So when we are talking about the consent from the clinical governors, you should talk about the frequent complications and serious rare complications. Frequent complications involve pain post-operative, colicky pain, spotting, infection. Serious complications include significant injury to the cervix, perforation. Perforation, exactly. Analgesia, it's recommended or routinely to give a non-steroidal injection around 1 hour before outpatient hysteroscopy. And this is the recommendation to reduce the pain. Cervical preparation before outpatient hysteroscopy is not recommended or not used, okay? It may be used in a very certain condition and just, okay, this is not from the guideline, this is from practice. What do you think if you would like to use only in postmenopausal? Asthma, use paracetamol before hysteroscopy. Yes, non-steroidals are contraindicated with asthma. So let me say also, what are the all treatments contraindicated with asthma in our curriculum, MRCOG curriculum? Dr. Suparna, you opened the door. So please Give me your suggestions. What are the labetalol? Yes, for hypertension management. Excellent. What's more? What is more? What about methergine? Carboprostant, methergine, prostaglandins, I mean. Excellent. Prostaglandins. Okay. Anything else? Smart candidates, smart friends. Anything else? Okay, remember this. Ulipristal acetate. Ulipristal acetate. Okay? As an emergency contraception. Okay? Okay, perfect. Just try always to collect ideas together. Okay, we are using outpatient hysteroscopy with a 2.7 millimeters telescope. Yeah, this is the ideal way to revise. Brainstorming, 2 or 3 friends together, sitting, trying to remember and collect different ideas, connect them together, and then you will never forget. Hysteroscopy, 2.7 millimeters diameter with a telescope, with a cover sheath. Cover sheath, yes, it's a part of non-steroidals, exactly. Okay. There is insufficient evidence for, okay, this is about the telescope. The camera is different in hysteroscopy. We have a 0 camera, 12 and 30 degrees cameras. Almost we are using a 30-degree camera in our practice in gynecology. We have 2 options for hysteroscopy, flexible and rigid hysteroscopy. And you can see from the, okay, maybe I have to maximize screen. Flexible and rigid hysteroscopy with the benefits or pros and cons of each one. Flexible are associated with less pain, but the rigid hysteroscopy is the recommended hysteroscopy by the RCOG, giving better image, fewer failed rates, and quicker in time. Okay. Rigid is our rule. The main rule is rigid. Okay. About the local anesthetic use, very common question about cervical or paracervical nerve block. A local anesthesia, rigid is better than flexible, yes. For our exam, for the MRCOG, okay. Okay, of course, paracervical local anesthetic block is recommended, okay, to reduce the pain and to reduce the incidence of vasovagal reactions. Always remember that the cervix is insensitive. Cervix itself is insensitive to injuries, to pain, to burn, to anything. The only thing which is the cervix is sensitive to is stretching, dilatation. Stretching and dilatation. So it's useless to inject local anesthetic inside the cervical canal itself. It's useless. So paracervical block is ideal to minimize the vasovagal attacks and decrease the risk of shock. Okay. There is an important point related to a very common complication, we can discuss it right now, is uterine perforation. Uterine perforation, there is a TOG article talking about perforated uterus. It's somehow an old one, 2013, but it's critical actually. The main point is the uterine perforation most commonly occurred by a suction cannula instrument. Then Hager dilators are very common as well. The most common site for perforation Anterior wall. Yes, it was prior to reading this article. It was all of the time in my mind that fundus perforation is the most common, but definitely anterior wall perforation is most common. And the very important trick in this SOG article, as well, we also have a summary for the SOG article. The most important thing is how can you manage a perforation? When to conserve and when to turn the patient into a surgical management. Okay, basically, all women with uterine perforation with good general condition or vitally stable, no excess vaginal bleeding, observation is your rule. Antibiotics, fluids, observation, vital signs. But there is 3 indications or 3 situations you will turn the patient into a laparoscopy even if she is stable with no bleeding. Number 1, yes, more than 5 millimeters diameter in instrument. I mean, the instrument who leads to perforation is more than 5 millimeters in diameter. This is the first situation. The second situation is avulsion of the endometrium. Avulsion of the endometrium, yes. Avulsion, maybe there is a behind injury rather than the avulsion. So avulsion of the polyp is an indication for laparoscopy even if the patient is stable. The last thing is perforation occurred by a resectoscope or electrocautery perforation. It needs laparoscopy. Laparotomy is preserved for vitally unstable patients. Okay? Vitally unstable patients only. Otherwise, laparoscopy, even if the patient is stable. So 1, 2, 3, avulsion, more than 5 millimeter diameter instrument, and finally, electrocautery or resectoscope perforation. If mentioned only, if mentioned only hysteroscopy, not size, then. If laparoscopy not clear, then also laparotomy. If laparoscopy is impossible or there is no a surgeon with laparoscopist surgeon with a good experience, laparotomy may be used, but the rule is laparoscopy. If said hysteroscopy only, no, it's not requiring laparoscopy unless the size of hysteroscopy port is more than 5 millimeters. Sometimes you may add, hysteroscopy alone as a telescope is 2.7 millimeters, 3.4 millimeters with the inner sheath. We may sometimes add outer sheath, which also named as continuous irrigation for prolonged procedures. When you add an outer sheath, maybe the size or the diameter will be more than 5 millimeters. But if the question is only mention hysteroscopy without size preferences, no need for laparoscopy if the patient is stable. Okay, perfect. Remember, there is a number have been changed recently. The risk of perforation or perforated uterus with gynecological procedure is 1 in 1,000. Previously, it was 5 in 1,000. Now it's 1 in 1,000 only. And the risk of perforation during ERCP, I mean after delivery, for retained placenta or something like this, It may rise up to 5%. Up to 5%. Okay? Yeah, this is new. And the significant risk for cervical injury will be 1%. Cervical injury will be 1%. Okay. This is the slide talking about prevention. How can we prevent possibilities of injuries during hysteroscopy? RCOG recommends the training programs, workshops, simulation sessions, and continuous upgrading by professionals in hysteroscopy use, prostaglandin administration prior to surgical termination of pregnancy, to ripening of the cervix, decreasing the risk of cervical and uterine injuries. Okay, all of these could be helpful. Cervical dilatation. Okay. This is the common sites as we discussed before. Common sites for uterine perforation and incidences. Okay. And this is the incidence of uterine perforation through different instruments. Okay. All of these factors may influence the risk of perforation as well. Okay, we discussed all this. This is a very critical flow chart. You should all of you take 30 seconds to see this chart in silence. Just 30 seconds, please. And take care from this point. Take care from this part of the cycle. Where is the arrow? Is placed there. 30 seconds. Okay, 30 seconds have been finished. I think the flow chart of the TOG article is very clear. Okay, very clear. And ideally, as we said, laparoscopy is the rule. Sorry. No, sir. Sorry. Yeah, I mean admit for observation. Yes, admit for observation, not admit for theater. Don't admit the patient to theater. This is what is meant by the admit in this, yes, in this one. Okay. Consent advice. We discussed the consent, serious complications. Yeah, this is what I was talking about right now. Okay. Sometimes you may have to remember mortality of the patients during laparoscopy and hysteroscopy. They are very similar in number. 3 to 8 women in every 100,000 may die during the procedure, as well as in laparoscopy, the same number. So you can connect them like this. Major complications in both hysteroscopy and laparoscopy will be 1 out of 500. And 3 to 8 women in every 100,000 undergoing hysteroscopy or laparoscopy may die as a result of complications. Same numbers, actually. Same numbers. Frequent risks, as we said, including bleeding, secondary bleeding, infections. The last thing you may have some information about is the Essure contraceptive method using hysteroscopy. The Essure is very effective. The results of success may lead up to 99 to 98, 99%. A metallic block is inserted through the hysteroscope inside the ostia bilaterally to block the tubes and then prevent pregnancy. Women should be continued or either continued on contraceptive methods or abstinence for 3 months, yes, until X-ray being conducted to confirm complete block of the tubes, and then you can yes, you can issue system. You can confirm successful issue insertion system. Okay, it's completely uncommon method, either to be discussed in OSCE station for contraceptions or for even questions coming like this, but this is the only important information you should know about. Okay, I think we covered the two items, laparoscopy and hysteroscopy, in a very simple way. I have there a controversy about issue now. Yes, actually, too many points have been all the time being changed. Lastly, the tape and mesh procedures. the rules now is all the rules now are completely against using the tape and mesh. Although TBT and TUT previously were a very famous procedure, for example, in correction of SUI, but they are changed. Now the hysteroscopic sterilization as well is in practice. It's not common at all to be offered because some conditions suffering from scape metallic portion through the intraperitoneal cavity, improper placement of the metallic part, and it needs a high expertising hysteroscopist to do it. So it's uncommon to be offered and uncommon to be asked in either part 2 exam or part 3 exam as well. That's it. To all friends who gave a time, effort, and attend the session today, I hope all of you enjoyed the information in a simple way, in concentrated points. These points are almost all important points. More than 80% of the exam will be from what we are discussed today. Thank you so much for attending, for your time, and I will be very happy if anybody have any question. This is the time of discussion. Any questions? Anything? Don't hesitate to open your mic right now. Okay, so I think I'm a good teacher. I'm a good one. All of you catch the small point. So no question.
Doctor,
okay, ask me.
Yeah, what about the media? We didn't discuss about media and how much which media, monopolar, bipolar.
Okay, you mean the electrosurgery?
Yes. Suppose we are doing the hysteroscopy, so which media is better to use and how much the deficit, and we will stop this one, the procedure.
Okay. Let me say something. The electrocautery technique, I mean the electrocautery biophysics and principles of electrocautery surgery, is a famous question in part 1 and part 3 at the station. But you need only the applied knowledge related to the electrosurgery for laparoscopy as well as the hysteroscopy for operative ways. The monopolar electrocautery is depending on both are closed circuits, but the difference is the closed circuit in both bipolar and monopolar has a positive electrode and negative electrode. The positive electrodes in both are similar. The difference is in a negative electrode. The negative electrode in monopolar electrocautery will be the ground or the patient herself. the patient, and then the extra charge will be transmitted through the ground. This is the negative electrode. The bipolar is more safe than monopolar, because monopolar, if the patient is not isolated well, and is this lecture recording available tomorrow though? Yes, available as soon as possible, maybe tomorrow night. TOG summaries is presented, yes. TOG summaries for most important TOG articles last 5 years, I think is available, yes. It's available through the course. Okay, and yeah, again, I have, what is the last thing I was talking about? Yes, the negative electrode, okay, is in the monopolar electrocautery, there is a risk for a burn for the patient herself, as we said, because she is acting as a negative electrode, okay, and in bipolar it's more safe. The two electrodes are on the same instrument, very near to each other, so the circuit is very small, very limited and located. For example, in the surgical forceps, the two arms of the surgical forceps will be the positive and negative electrode. This a very important thing in hysteroscopic surgical maneuvers, because the media which used to distend the endometrial cavity should be different between the monopolar and bipolar maneuvers. We have three options for distension media. All of you knows CO2, normal saline, and glycine. CO2 is not used anymore nowadays. It depends on the surgeon experience and associated with different side effects and risks. Although the best image associated with CO2 distension media. Now we have to choose between saline and glycine. Saline and glycine. Saline is ideal for diagnostic procedures and bipolar electrocautery. Normal saline for hysteroscopy with bipolar monocautery. But if the machine is monopolar, glycine will be ideal. Glycine will be ideal to prevent monopolar glycine. Yes. Okay. Monopolar will be ideal for glycine. Bipolar for normal saline. Okay. Because the normal saline, the electrolytes in normal saline, including sodium and potassium, are a good conductors for electricity. So they may spread sparks everywhere. Exactly. Okay. Yes, I think we are finished. I hope all of you enjoyed the session, as well as the previous session with Dr. Sidra. I know she is so professional, and I liked her session as well too much about GPS, because all of the time when I was studying, I hate GPS guidelines. I have some guidelines. I hate them so much. But with Dr. Sidra, I liked her way in explanations and in discussion of GPS. I hope all of you gain too much information and being more confident with laparoscopy and hysteroscopy questions. Please, all of you, even you will join or not, please participate and practicing questions related to laparoscopy and hysteroscopy, and send the queries and the difficult ideas to me to discuss it all together if possible. So it will be great for me, a great honor, as well as it will be very beneficial for all of you to new ideas and new tricks in questions. Okay. Sorry, in your course, all session by Dr. Hasan or by Dr. Sidra? Both. Yeah, actually, yeah, this is my course. I mean, I will be the main instructor, but Dr. Sidra is an instructor in the Part 2 course, and she is very brilliant in certain topics. So she will be responsible for a session related to these topics. She's better than me actually in certain issues. So I prefer her to present these issues by herself. It will be more beneficial to all our candidates and our colleagues. And that's why both we are together in this course to deliver the maximum possible effort and ideal effort to all of you. Okay. Okay. Yeah, I think the lecture days will be Saturday and Wednesday. I think, Dr. Sarwa. Saturday and do you have study? Of course, we have a Facebook study room which is very active. Sometimes I'm being very confused and exhausted, very exhausted to answer about 50 to 70 questions per day. So it will be horrible. So just join it and try to sleep at night. You will fail. The mobile all of the time. Okay. So the next session will be, next topic will be in the regular course on 2nd of April, as I remember, the 2nd of April. We will start with gynecology modules. It will be early pregnancy complication session. Early pregnancy complication session. Yes, of course. We will. Dr. Hassan Haider will contact all of you and will send the link for the group on Facebook. Okay. Thank you so much for all of you, and have a nice night. I appreciate too much all of your attendees here. Thank you. Just a second. What about SBA with topic? Which SPA? The records will be available as soon as possible tomorrow. SBA with topic, I can't understand the question, Dr. Shazia. I'm sorry. Please repeat it again. Thanks a lot. I mean, on email. I mean, if you can bring SBA with topic. Yes, this issue, the single best answer or EMQs related to topics, certain topics, is available on the Facebook group. Okay, questions will be posted regularly related to each session we have finished, so you can catch it on the Facebook group. Thank you so much. Have a nice night. Enjoy. Bye bye. Thank you.